All right, welcome back. This week we are going to do a quick review on some of the public health uh, content that we started on last week, and then we're going to move into cognitive function. So outside of the public health content that we had shared on, the goals of this session are to be able to describe the importance of different cognitive domains and their assessments, explain physiologic mechanisms linking physical activity to cognitive function, things like BDNF, neurogenesis, and hippocampal growth, identify variables that determine the effects of exercise on cognitive function, thinking about acute versus chronic physical activity, the type of physical activity, and demographic variables. Interpret standardized mean differences that's specifically related to your article content for this week, and then apply these concepts to real world examples. So I wanted to review some of the content that we started on last week because I felt like I rushed through it a little bit. And it is important content to understand partly in the formulation of your thoughts around your final paper. So in any case, this demonstrates how public health functions, right? First, we surveil. We look at cross-sectional studies and cohort studies, and we see what's happening in the population. Through that process, we identify risk factors, right? Some partly also through cohort studies and then randomized controlled trials. In those randomized controlled trials, especially, we start to develop interventions. We start to see what works. What are the risk factors for the health outcome that we're interested in? How do we intervene and either treat that health outcome or prevent that health outcome? And then implementation is really where we find out, okay, now if I apply that intervention, I know after a bunch of intervention studies, I know what's working. How do I then apply that on a population level? And how do I communicate those findings to large populations? So that's DNI is dissemination and implementation research, and Paul's going to come talk to us about that. Looking at the surveillance and observational piece, I just wanted to mention this because blue zones have been in the media. They're pretty popular. And it's part of the surveillance and observation piece, right? Blue zones aren't in that, maybe a little bit in the risk factor identification piece, uh, but we're definitely not in the intervention development piece yet. So the blue zones are areas of the world where you have the highest concentration of centenarians, so individuals over the age of 100. And in some of this observational data, they were able to identify 9 characteristics that were common to those blue zones. And they're listed here for you. And also, if you look in the slide notes, there's some data on these variables. What I thought was more interesting was actually the figure on the left, was looking at how different aspects of our environment contribute to healthy behaviors. Okay. When considering environment, one of the ways that we can curate our own environment is through organizational intervention. In this case, we're looking at the federal government. So I ran through how physical activity guidelines are created, right? And we had the 2008 physical activity guidelines in the US, and then we updated those in 2018. Theoretically, there may be an update in 2028, but we may also decide that we don't actually need an update. Those physical activity guidelines are what determine our 24-hour movement guidelines, which I've outlined here for you, and there are some citations in the slide notes. I do think it's helpful to understand that different countries and different organizations may have slightly different guidelines. You'll see that there's a lot of overlap, certainly, but as I pointed out in class, the Canadian guidelines are the oldest guidelines, and they sort of are the global leader in this regard with the 24-hour movement guidelines. They're the only ones who have a sleep guideline and also a sedentary behavior guideline. So the US's only sedentary behavior guideline is move more, sit less. Who has some guidelines like limiting SB, so sedentary behavior and screen time, but Canada actually has numerical values associated with those things. And then the UK has some, but it's not super specific. Okay, so in any case, this is a very helpful resource when thinking about public health interventions, how they're developed, right? Understanding that, hey, these guidelines, these reports that are 770 pages, make up how we communicate physical activity guidelines to an entire population. So they are pretty important. So the purpose of those guidelines, right, is to inform or rather to be a resource for health professionals and policymakers. And I did want to outline a couple of ways in which those guidelines are actually used. So the Department of Health and Human Services released Healthy People 2010, 2020, and will release 2030. And that's based directly on that 770-page report, with the explicit goal of increasing the proportion of adults who meet the federal guidelines for aerobic physical activity and muscle strengthening activity. Okay, that's the goal of Healthy People, which was developed from those physical activity guidelines. Okay, other things, other interventions that have been used in the past. The CDC runs they're one of the organizations that developed the Presidential Youth Fitness Program, which started in the 1950s and was actually discontinued in 2017. The Presidential Youth Fitness Program started in 2012, adopted the Fitnessgram, which had been previously adopted by several states. The Fitnessgram the big thing about the Fitnessgram was that it differed from previous testing on children and adolescents particularly, and focused less on athletic performance and more on health-related components of fitness. So the Fitnessgram includes the PACER test, which is a measure of aerobic capacity, the push-up test, the curl-up test, looking at upper body muscular strength and endurance, the sit and reach, looking at flexibility, and then BMI and skin folds, looking at body composition. So really a health-based approach was the shift there. The Fitnessgram physical activity guidelines also influence state policy. So Georgia and Texas specifically were some of the first states to adopt statewide physical activity programs or required assessments. In this case, they require children to be tested via the Fitnessgram once a year. And other states have similar guidelines, but Georgia and Texas are for sure the most strict. Physical activity guidelines can influence school policy, state policy as well, right? So education is regulated mostly at the state level. So do we mandate PE? Do we mandate recess? But the federal government and the guidelines that they came out with can influence those policies. They can also influence things like how much green space is set aside in a given city or in a given development. And then private sector can also be influenced as well. So a lot of companies are starting to employ health and wellness coaches of some kind to help develop a wellness program to keep their employees healthy. So that's how those physical activity guidelines really play out in the real world. It's not enough to know the guideline. You have to have an environment that supports people in achieving those guidelines. So that contrasts with the idea of healthism, and healthism is the idea and the belief that health is every individual's responsibility, and it doesn't acknowledge the sociocultural and environmental factors that can influence health. So if we then develop an intervention that addresses aspects of health that we're interested in improving, how do we know if it worked? So some of the things that we might measure are Life's Essential 8. Again, I have these listed in your slide notes, but really briefly, the Life's Essential 8 is produced by the American Heart Association, and it includes things like diet, physical activity, nicotine exposure, sleep health, body mass index, blood lipids, blood glucose, and blood pressure. So those are things that we might measure on an individual level to see if an intervention worked. On a global level, we look at something like the Human Development Index, and that measures a lot of different or very few things is what I meant to say. So we're looking at life expectancy at birth, right? So how long are you likely to live? Expected years of education, and then the gross national income per capita. Okay. What I think is helpful to think about though is what might be missing from these. And when I ask that, especially with the Human Development Index, what I might be thinking is if I were you, where would I want to live? What are some metrics that I might want to know in a place that I am interested in living? So things for me that might come up, and you can make a list, right, on Perusal if you want, but things like safety, things like sex and race-based inequities. Does wealth distribution look like in the country? What does poverty look like? What are happiness and quality of life scores like? Right. So there are other domains and aspects of health that I might be interested in that aren't captured in some of these measures. And then I just wanted to end this recap with, okay, so what are we then doing, at least at the university level? So what are some ways in which Utah or the state government supports healthy living? And at least at the University of Utah, your tuition pays for a counseling center. It pays for academic counseling. It pays for a food pantry, pays for a financial wellness center, and pays the office of the dean of students, right? Your tuition doesn't just go to pay for classes. It goes to pay for these other things, these other services that are free or at significantly reduced cost. So, for example, I think the University Counseling Center, I think one session is free. And then after that, if you continue with the counseling center, I think it's maybe $15 a session. And just for reference, if you're seeing a therapist outside of that setting, you can be looking up as high as 100. It's not uncommon to see $150 a session. So in any case, I encourage you to use these resources. If you need help finding appropriate resources, you can always come to me and ask. The Office of the Dean of Students is an excellent place to start if you're not even sure where to go. Um, so just know that right there are these safety nets in place for you here. And the university, several of you mentioned in the perusal from uh, the perusal article about undergraduate health behaviors, you talked about, I feel like the university really has a role here and the university needs to be providing XXXX. These are some of the things that the university is providing. So I hope you take advantage of them. Now, I did want to provide you a chance because I didn't in class, but to answer this question and maybe have some discussion about it on perusal. But at what level, individual, institutional, governmental, or global, do you think the greatest leverage lies for improving population well-being? And at what level does the greatest responsibility lie, right? So uh, leverage and responsibility are two different things, right? So what is actually going to result in an effect, and then where does the responsibility lie? And they may result in the same answer, right? But those are two different questions. So where's the greatest leverage to improve population well-being? And at what level does the greatest responsibility lie? Who's ultimately responsible for the health of the population or the health of the individual? And I just like to generate a little bit of discussion around that because it's pretty relevant when talking about public health. Okay, we're going to take a quick break and then jump into cognitive function.